Hello, and welcome to Ethically Speaking, a UCF interdisciplinary series on contemporary moral issues. My name is Steve Kubler, and I'm the organizer of this series, and I'm professor of chemistry and optics and founding associate director of the UCF Center for Ethics. In today's event, Dr. Bryan Cwik will tell us about the rapidly changing landscape of biotechnology, global health, and related ethical lessons we can take away from the COVID pandemic. But before we introduce Dr. Cwik, I'll take a moment to tell you about this speaker series and how you can participate. Ethically Speaking is organized through the UCF Center for Ethics with my collaborator, Dr. Jonathan Beaver, Associate Professor of Ethics and Digital Culture and founding director of the Center for Ethics. We developed Ethically Speaking to promote conversations about challenging issues of our time, and we encourage you to visit the center's website at ethicscenter.research.ucf.edu to learn more about our activities and to find out about other speakers in our series. We would also like to hear your feedback and your ideas for future talks in Ethically Speaking. UCF is leading the way among major metropolitan universities in how we place ethics front and center in all of our work, including the professional training of our students. And the importance of ethics at UCF is clear from the long list of partners who co-sponsor this series. All of us in this partnership hope you enjoy the discussions in Ethically Speaking, and we hope it cultivates understanding of how ethics provides frameworks for making better decisions, particularly when there are competing values. Today's presentation is being recorded, and links will be posted through the Center for Ethics so you can share it with others. At the end of his presentation, Dr. Cwik will take questions moderated by Dr. Beaver. You can submit questions using the Q&A box, and you can also upvote questions that interest you. Now we will turn to Dr. Jonathan Beaver, who will introduce our speaker.
Thanks, Dr. Kubler. It's really my pleasure to introduce Dr. Bryan Zwick. Bryan's an assistant professor of philosophy and university studies at Portland State University. He's held previous positions at UC San Diego, Indiana University of Pennsylvania, and Penn State. He took his PhD in philosophy from the University of Virginia. I first met Bryan when we overlapped postdoctoral appointments several years back. I found then that he has an almost polymathic capacity as a philosopher, interested in and more importantly, capable of engaging a huge range of philosophical concerns. Central to Bryan's research, teaching, and thinking right now are concerns about bioethics, specifically about the impacts of healthcare and biomedical technologies on our individual well-being and our collective public health. Here are deep-seated and complicated issues of justice and equity, harms and benefits, and the extents and limits of free action. His work emphasizes the ethical and the political philosophical implications of emerging technologies. Dr. Cwik has written on ethics of gene editing, diagnostic justice in COVID-19 testing, climate risk modeling, property rights and labor issues, and he's currently working on a textbook on ethics and biotechnologies. His work on the ethical, legal, and social implications of germline gene editing has been supported by the National Institutes of Health. He also plays hockey, for which we're not going to judge him negatively, and he has at least one cat, for which we can judge him positively. It's really my pleasure right now to welcome you, Dr. Cwik, to the UCF Center for Ethics Ethically Speaking seminar series. Take it away.
Thank you very much, Jonathan. I don't really play hockey anymore because I'm old and there's not much hockey in Portland, and I have a second cat now. So none of the bad stuff and more of the good stuff, apparently. It's very nice to be here with all of you. I'm coming to you from my home right now in Portland, Oregon. Apparently I have a slightly unstable internet connection, so if I break up or freeze for a second, I'm sorry. I'll just try and go back and repeat it. I want to thank Dr. Beaver and Dr. Kubler for inviting me to speak. It's a great honor to be here to talk to you all. I am going to share my screen right now. I have some slides for this presentation. Hope you can all see that. Okay, cool. So I'm going to talk for about 30 to 45 minutes, and then there will be questions at the end, as they said. Before we start, just a couple disclaimers to be safe. I don't have any specific financial or any other conflicts of interest related to COVID. Just for good measure, I'm a member of the External Advisory Board for the Center for Embryonic Cell and Gene Therapy at Oregon Health and Science University. I do not receive an honorarium for this. They're not doing anything with COVID right now, but in just in case in the future, if they develop some kind of treatment, I don't want to have retroactively had a conflict of interest I didn't tell you all about. I am not a medical doctor or an epidemiologist, so please do not take anything I say here as either medical advice or as public health policy advice. This is solely about philosophy. Okay. I don't think we need to talk much about the incredible impacts that the COVID-19 pandemic have had and continue to have on our world. I think it's really actually impossible to do anything except understate how big of an event this has been. The world has been turned upside down. Just about every part of life in every corner of the world has been shaken up pretty significantly. And we will, very likely be unpacking the impacts of COVID for a long, long time, maybe hundreds of years into the future. I mean, we're still talking about things like TB and the Black Plague hundreds of years in the future. And this is genuinely comparable to that. One of the reasons why these things become huge events and need this much analysis is because epidemics are never just epidemics. They're never just about mortality and medicine and disease. They're always about politics, culture, and social and economic structures. This is one of my favorite, very succinct, I think, statements of this from the medical historian Frank Snowden from his great book, Epidemics in Society. I mean, epidemic diseases sort of expose these deep structures within particular polities, societies, within economies. They show us sort of things that we don't necessarily see all the other time, all the rest of the time. They're, big deals. They affect not just one part of life, but they affect everything. And COVID has certainly been that kind of thing. There's a bunch of stuff we could talk about COVID. A lot of it has been talked about to death. Some of it has not been talked about very much at all. I want to talk about one of the things with you today that hasn't been talked about very much at all, and that's the role of medical innovation, emerging medical technologies, or I'm just going to use the broad term, biotechnology, in the pandemic, and what kinds of lessons, specifically ethical lessons, but just lessons generally, we can draw from the role that biotechnology has had in dealing with this particular pandemic. So here's what we're going to do now. I am going to talk a little bit about COVID generally, just to give some context. I mean, I think it's important, and I think we should all get on the same page about some of the features of the pandemic that are relevant to this talk. But also, I just want to talk about COVID because it's been, not to minimize the real suffering and pain that COVID is causing, but it has also been a very interesting event for people, like us, like me, study and try to understand the world. This has been the most important event in recent years. It might turn out to have been the most important event in my life so far. And it has been a big challenge unpacking all the different angles of it. So I want to just talk a little bit about that. And then I'm going to talk a little bit about some views about biotechnology in global health ethics, what I'm going to call the received views about this. And then we'll go over, I'm going to go over a couple of key technologies, 3 specific key technologies that have been instrumental in the world's response to COVID, and finally draw some lessons about the role of biotechnology in global health for the post-COVID world from the way in which these 3 specific technologies have featured in the world's response to COVID. Okay, so to begin with, one little piece of context that is particularly important to me. You hear 2 words all the time when people talk about COVID. It's unexpected and unprecedented. This is something that's brand new. Nobody could have predicted it. It wasn't like really, it just came out of the blue. It's a black swan event, a huge natural disaster. The only precedent for it is 100 years ago, the Spanish flu. This is something that shouldn't happen in the 21st century world, where epidemic disease is a nuisance and not this huge emergency like it used to have been. That is just not true. COVID has neither been unexpected nor unprecedented. Let's start with the second part, the unprecedented part. The best analog to COVID is, in fact, the Spanish flu from 100 years ago, but the Spanish flu was not the very last epidemic disease event in the world. There have been a whole bunch since then. In fact, the history of the 20th century has, in part at least, involved successive major epidemic disease events. So just here's a couple. This is just stuff like, I literally, just to illustrate how ubiquitous this has been, I assembled this list just off the top of my head, not research it. I was just like, oh, what are the ones that I can really remember hearing about over the course of my education that are big ones? So polio in the United States, just take 1 year of the US polio epidemic, 1952, that was a particularly bad year. You had 58,000 confirmed cases. It killed 3,200 people. Almost all of them were between the ages of 9 and 12. And 21,000 of those cases are people who had a permanent disability as a result of polio in that 1 year. Polio is still kind of within living memory. I bet a lot of you listening to this have some experience, family experience with polio. I certainly do. My grandparents' first child died not of polio, but actually because of polio. Their first son, Jeffrey, spiked a huge fever one day, and they took him to the hospital, and the doctors looked at him and they said, he doesn't have polio, but also we don't have any beds for him. We can't help you. It's just a fever. It'll go away. So, take him home and it will resolve in and of itself. It turned out he had a fever because he had strep throat, and it turned into rheumatic fever, and he died as a result of it. So he quite literally is a casualty of the polio epidemic, not because he had polio, but because polio filled up every bed on the northwest side of Chicago, and he couldn't get treatment. Another one that is in living memory, but isn't much discussed in the United States, the third cholera pandemic, which is generally held to last between 1967 and 1975. The result of this is that cholera has been with us ever since. It's become endemic in certain parts of the world. This is almost certainly an undercount, but confirmed cases from this pandemic, from the third cholera pandemic, were 1.2 million. Almost certainly it's much bigger than that. Nobody is quite sure how many fatalities there were as a result of it, but the reported case fatality rate of cholera during the third cholera pandemic, so in the middle of the quite literally in the late 60s, was 16%. Cholera, that might be surprising because cholera is a disease that can be treated with antibiotics pretty easily, and it's a disease from the 19th century, and yet here, the third pandemic began in 1967. It killed tons and tons of people. Surely it killed millions of people. And cholera has kind of been around ever since then. The 1957-1958 flu pandemic, somewhere between 1 and 4 million deaths globally, although that's probably an undercount. In the United States alone, killed 150,000 people. The US population in 1957-58 was 170 million people. So to scale that up to our current population, that would be like losing 290,000 people. Obviously, we've lost a ton more than that over the course of the last 2 years from COVID. But even if COVID ended up just costing 290,000 lives, that would be considered a pretty significant event. And that is what happened during the 57-58 flu. The granddaddy of them all over the last 100 years has been HIV/AIDS. The estimate is that HIV/AIDS, since its sort of worldwide spread at the end of the 1970s, has cost 32 million deaths, making it one of the deadliest infectious diseases in U.S. in history, period. That's probably an undercount as well, because death from AIDS is pretty non-specific, and so in countries with poorer healthcare systems and tracking of mortality, lots of these deaths probably went unnoticed. But AIDS is not something from the distant past. I mean, we're coming up towards the 50th anniversary of the beginning of the HIV/AIDS pandemic. It is a 20th century and now 21st century disease. Well, I mean, just a brief survey. Epidemic disease didn't go away in the middle of the 21st century and become a nuisance only to come back now in this unexpected way. There's been plenty of precedent for it. It has never really gone away. Infectious disease has continued to be a feature of the world in the post-World War II era. And the COVID pandemic is not the first one. It's just the most serious. Well, I mean, or at least the most compacted one, the one where the seriousness was compacted into the smallest time frame of the ones that have happened. It certainly has not been unexpected. I've been studying medical ethics pretty much for my entire adult life, and these are just some of the ones I can remember off the top of my head as big pandemics or sort of big events that kind of tipped off the world to the threat of emerging infectious disease. There was SARS in 2002, 2003, spread around the world, killed 800 people, infected somewhere around 8,000. There was a big scare about H5N1, which we just call bird flu or avian flu. It had been confined mostly to southeast parts of China, and then strains of it began spreading around the world in 2005, 2006, and infected people in many different parts of the world, but never actually sparked a pandemic. Transmissibility for this virus remains really low, but it really scared a lot of people. H1N1, what we call swine flu in 2009, 2010, that scared a lot of people too, but turned out to be kind of it wasn't a huge event. It did kill 12,000 Americans that year. H7N9 in 2013 began infecting people in Beijing and several of the big cities in China. Again, transmissibility remained low and it never turned into a huge effect. Then there was another coronavirus, the second one since 2003, Middle Eastern Respiratory Syndrome, or MERS. MERS is very deadly, but again, not very transmissible. It did cause big outbreaks in some urban areas in Seoul, South Korea, for example, but it never really took off. And then, of course, there was the Upper West African Ebola epidemic, 2014 to 15, which killed many tens of thousands of people. Everybody knew that at some point in time, something like this was eventually going to happen. Anthony Fauci, who was in charge in various different capacities of parts of the US response to COVID, gave a speech on January 10th, 2017 at Georgetown University, in which he listed all of these different things and had this great quote: "The next president will deal with something like this. We will definitely get surprised in the next few years." This had been coming for a long time. Something like this, most people believe something like this, one of these things was eventually going to emerge and get loose. It was inevitable. And really, it's, to me, studying medical ethics, my entire adult life, it just felt like I'd been waiting around for something like this to happen. And most people I know who are pros have been waiting around for something like this to happen sooner or later. And then it did happen. COVID is very different from a lot of these other things. Of course, it is a majorly impactful event. It's had, just the economic impact alone has been gigantic. It's not at all like, the third cholera pandemic, for example, but it certainly wasn't unexpected, and it definitely wasn't unprecedented. It was just sort of like one of those things that seemed like it was eventually going to happen, and we had been preparing for a long time, and then it finally did strike. Well, I want to illustrate just two dynamics. One is pretty relevant to what I'm talking about today, and one of them is just, I think, really interesting, and I want to mention it anyway. One of the major dynamics here is the relationship between COVID and age. As everybody knows by now, risks of COVID are heavily associated with age. It's not just risky for aged people, but the risks go up very significantly with age, even in the absence of other underlying medical conditions. This is kind of an interesting and important thing, because right now, the 65 plus world population is higher than it's ever been in world history, in human history. There's never been as many people over the age of 65 on the planet as there is right now. It is a major demographic phenomenon, one that is been heavily discussed, the graying of the world. Sometimes you'll hear that phrase used. And it is, I think, no coincidence that COVID has been so impactful, given that it has entered the world at a time when the people most at risk for the disease are at that population of people is at the highest it's ever been in human history. Just to give you a comparison here, 1957-58 flu pandemic, again, there was around 150,000 US deaths. 50% of them, around 50% of them, were in the 65 plus population, which is typical with flu. The rest of them were heavily concentrated in children, which again is a kind of a typical mortality curve for flu. At the time, the United States 65 plus population was around 9%. 9% of the 170 million people living in the US at the time were 65 and older. COVID, the US population of 65 plus is around 17%. And in some parts of the United States, it's much higher. In Florida, for example, where you all are right now, it's almost 20% of the population of Florida is over the age of 65. 80% of the deaths from COVID worldwide have been in people 65 plus. So, I think it's fairly, oops, sorry. I want to go back, but I don't want to, no, can I go back? There we go, all good. Pretend you didn't see that next slide yet until I start talking about it. Well, I think, I don't mean to say this, what I mean by this is not to say COVID is only a big deal because there are so many people age 65 plus in the world. It would be a big deal even if that wasn't the case. But certainly the population structure, sort of demographics of the world population right now, the fact that the world there are so many 65 plus people living in the world, in countries like the United States, and especially in many countries in Western Europe, the 65 plus population is very large because that is sort of the demographic facts on the ground. COVID has been, that is definitely a big part of why COVID has been so impactful. Not to say that it wouldn't have been impactful otherwise, just to say that this is a dynamic that certainly has meant a lot for why the pandemic has gone kind of the way that it has. Another one, this actually doesn't really have anything to do with the talk I'm going to give. I just want to talk about it because I think it's really interesting. I go over this with my medical ethics students. Now, this will be the third term I've taught medical ethics since the start of the pandemic in 2020. And we go over this always. Most of my students, where I teach is very similar to UCF. It's a public access university. Most of my students are over the age of 25. Most of my medical ethics students are actually working in the healthcare profession right now. They're medical assistants or they're scripts or something like that. So we've gone over this every time. This will be the third time we go over this. I go over this with them, and because their final question at the end of every term is, at the end of their final question on the final is, do healthcare workers have a duty to treat patients even in an emergency like this one, even at risk to themselves? And it's really fascinating to get their answers. Many of them are working in healthcare right now, and some of them are even working with COVID patients while they're going to school. It has not historically been the case that healthcare providers have a duty to treat in emergencies. It kind of is a little bit now. The American Medical Association Code of Ethics says that, physicians are free to choose who to serve, but in emergencies, they may have their freedom to choose who to serve attenuated a little bit, but there's a, sort of qualifier there. Physician workforce is not an unlimited resource when providing care in a disaster with its inherent dangers. Physicians also have an obligation to evaluate the risks of providing care to individual patients. This has been perceived, at least, as opening up some sort of room for physicians to exercise what has historically been a right to make decisions about when to practice and who to serve. In other emergencies in the past, like the Black Plague and in the early days of HIV/AIDS, many healthcare workers acted as if they had, unlike in other emergencies in the past, where healthcare workers were choosier, let's say, and many, for example, in the early days of HIV/AIDS would refuse to treat AIDS patients. During the COVID-19 pandemic, healthcare workers have consistently acted as if they have a duty to treat COVID patients, even despite significant risk to themselves. The number of healthcare workers worldwide who have been infected with COVID is very large. And even despite lack of political support, public cooperation, shortages of personal protective equipment, and things like this. I think this is just fantastically interesting. It heralds a sea change, actually, in terms of the long sweep of medical history. It heralds, it shows the entrenchment of a sea change that sort of started to happen around the SARS epidemic, in how healthcare workers viewed their obligations to their communities. But it also kind of shows an important sea change, I think, in the way in which medicine operates, the role that it has in the modern world. And this has been one of the things that's very interesting about COVID. COVID has brought to the fore some of these important features about the role that medicine now has in the world and in our lives. I mean, one of the aging of the global population has made demand for certain kinds of medical services and vulnerabilities to certain kinds of medical risk much higher than they had been in the past. Medicine is just sort of, this is something that I think is often missed, or not missed per se, because that makes it sound like it's everybody's fault, but I just think it's just not noticed. In our lives now, medicine, medical professionals, a doctor, they're just like a part of life, right? So many parts of our lives are completely medicalized: reproduction, end of life care. I mean, all of these things are done in healthcare settings. Going to see a doctor, receiving basic primary medical care. I mean, medicine is just part of your life. It's not considered a luxury in the way that it has been in every other part of human history up until very recently. It's just something that's there that we do. This is a very new thing. Up until the middle of the 20th century, and doctors were luxuries in a certain kind of way. I mean, it would never have been that the role that medicine has in our ordinary life is very much bigger than it ever has been in the past. And concomitant with this has come this sort of acceptance of the idea that public health is very important and states have obligations to secure public health. The entire response to COVID has been understood in terms of government has to do something They have to provide money for research of new treatments. They have to take public health measures to shut down transmission. That has been just the framework in which we understand this particular epidemic. We all operate now, we all live in a world in which public health is just something that is there, and we think states have obligations to secure it for its people. This is different from other epidemics like this in the past. It is also, I think a noteworthy thing here is that it's totally unacceptable to have mass casualties from an infectious disease. The world has been willing to sacrifice enormous amounts of economic output to preserve life. This was not the case with other epidemics. It certainly wasn't the case with the Spanish flu. It wasn't even really the case with the 1957-58 influenza pandemic. That was, sometimes people write about that and they're like, oh, nobody even noticed that was happening. Actually, people did notice it was happening. I mean, schools shut down early in the winter of 1957, for example, because of wide understanding about a worse than usual flu year. There's a very intriguing sociological thesis that the flu pandemic hastened the transition away from mass use of mass transit in the United States. But I mean, measures were very light. Not much was taken. I mean, we completely shut down the world economy to prevent as much as possible deaths from COVID. The total lost economic output over 2020 is estimated to be about $16 trillion. I mean, that is an enormous amount of lost economic output. There have been dissenting voices certainly about it, but for the most part, I mean, it's just been clear that the world has just found mass casualties from an epidemic of this kind to be totally unacceptable. It has exposed continuing massive disparities and structural injustices in health and healthcare provision, both internationally, but also intranationally. I mean, this is something the United States, this isn't something I'm going to talk about in this particular talk. It's been very much discussed, and it should be, because it's something that within the United States, we're going to have to spend some time coming to grips with, is the way in which there are still these massive sort of disparities in healthcare provision and how much this has impacted the seriousness of COVID-19 in the United States. But then there's this one thing that is sort of, I guess you could say, a minor theme in the story of COVID over the last couple of years, but it's the one that I'm talking about right now. And this is the role of biotechnology in public health, in the public health response to COVID. So let me start a little bit, just sort of fill in the blanks with a very brief and sort of overview of how biotechnology is viewed within the field of global health ethics. I'm just going to call these the received view or views. It's not clear they're one coherent view. It's just but they're generally things that people think are the case that are kind of out there. So by biotechnology, let me start with just by biotechnology, what I mean, I'm just going to use it as a catch-all term for emerging medical technologies, work in life sciences towards developing new pharmaceuticals or therapeutics, medical innovation generally. It's a bigger term than that. Biotechnology also means things like agricultural biotechnology. I don't really know. I mean, other terms are just clunkier. I could have called it emerging medical technologies or emerging medical innovations. The word biotechnology is widely enough used. So understand what I mean by biotechnology from here on out as development of new medical innovation. When it comes to discussion about global health ethics, the role of biotechnology is very minimal. It's generally accepted that the central ethical problem in global health ethics is the injustice of persistent clinical deserts. I love that phrase. That's from the global health theorist and physician Paul Farmer. The fact that, in other words, there are some parts of the world and in developing countries, but also within some developed countries, in which there's just very minimal to no provision of even basic primary and trauma medical care. And this makes a massive difference in just about every area of life. When it comes to discussion in global health ethics about biopharmaceuticals, the central concern is always access to essential medicines, to antibiotics, childhood vaccinations, antiretroviral drugs for HIV/AIDS. And to the extent that medical innovation enters into that at all, it's usually a discussion about how little incentive there is to do research and development of new therapeutics for diseases that aren't a big problem in developed countries anymore. For example, work on drugs for malaria, for hemorrhagic fevers like Ebola virus disease. That's actually kind of just a small corner of it. I mean, the central concern always has been trying to figure out ways to get around existing international intellectual property institutions that are perceived to be a huge barrier to access to what are called essential medicines. focus on biotechnology and access to medical innovation in global health ethics is often argued to be misguided. This sort of position has actually become much louder in recent years because there is so much work in medical ethics on biotechnology and emerging medical technologies. There's reasons for that. Part of the reason is just they pose really significant and important and interesting ethical problems. But a louder voice, a louder crowd has been arguing that this focus is a little bit misguided. I mean, and behind this is an assumption that medical innovation doesn't really, cutting edge medical technologies don't really benefit people towards the bottom end of the world income scale who live in clinical deserts. They have nothing really at stake in the latest cancer drug or other things. And sometimes you'll hear global health theorists talk about pharmaceutical innovation as if it's just about, new erectile dysfunction pills or acne medications. And there's a general sort of feeling out there that ethical work on biotechnology and access to medical innovation, when it comes to global health ethics, it's just kind of misguided because the biggest problems have nothing to do with medical innovation, and medical innovations don't trickle down to benefit people who are at the unjust receiving end of inequities and access to basic medical care, at least for a long time. So this is the view, I think, the COVID pandemic, this is what I want to argue today. I think this is the sort of set of views about biotechnology and global health ethics. I think the COVID-19 pandemic has really challenged. I actually think that one of the lessons we should take away from COVID is how important certain kinds of medical innovations are in dealing with events like this, even though these are epidemic diseases are, a challenge from the medieval past. We have relied very heavily on 21st century medical technology to deal with this one. And a big story about things like the inequalities and impacts of COVID has been down to inequalities in diffusion of and access to these big time medical technologies. So let me list three of them. Three key technologies that have been a major part of the world's response to COVID-19 and that have all of these two are ones in which access to these technologies has shaped in a big and important way inequalities and impacts of the pandemic. So the first one is, I don't think any surprise to anybody, the creation of the mRNA vaccines for COVID. I mean, it is very hard to overstate how big of a game changer mRNA vaccines are. This is a novel way of making vaccines. It's not a novel kind of vaccine per se. I mean, it still just depends on the same deal as other vaccines, inert proteins that trigger an immune response and help you fight off an infection from the disease. But the way of making these proteins, and especially the rapidity, the speed at which you can go from seeing a new pathogen to making a vaccine for it, and for that matter, the efficiency in which you can make vaccines for different kinds of pathogens. This is an absolute game-changing technology. mRNA vaccine platforms have been around for quite a while, and there's been a lot of discussion about making vaccines with them, but there's just been no real way to get it done because it's so expensive to make a new vaccine. There's almost no return on investment for it, and it just would take a huge commitment of resources to get new vaccines with this technology out there. But there's been people working on it. For example, there's a lot of work about a universal flu vaccine that uses mRNA platform, Ebola vaccines that use mRNA platforms. COVID-19 pandemic obviously changed that. Operation Warp Speed in the United States, which invested billions of dollars in vaccine development, took all the risk out of finally using this technology to make a new one. The vaccines were made. The technology held up to its promise. I mean, it allowed the making vaccine candidates were available very quickly. Manufacture of the vaccines, the doses themselves, was able to happen very quickly, and what is now the world's largest clinical trial was conducted over the course of almost the better part of a year to test them. Hundreds of thousands of volunteers on 5 continents, and they turned out to be effective. I mean, the technology worked the way everybody hoped and wanted it to. I mean, the idea of creating it is very hard to overstate how big of a deal it is that the world was able to create a vaccine for a brand new pathogen in less than a year and start getting it widely distributed to millions of people within a year of the pandemic beginning. This is a true game changer. And mRNA technology is not going to be useful just for COVID or even just for diseases like this. There's already discussion about using it for cancer vaccines or a universal flu vaccine, creating new vaccines for malaria. This is a technology that's been simmering for a long time in the biotech world, and its time has finally come. This one, though, I think maybe is a little bit less understood or appreciated, the real importance of rapid diagnostic technology and bioinformatics in this pandemic. We all have been subjected to and talked a lot about testing, the importance of testing, the role of testing data in smart public health measures and in contact tracing. Well, all that testing depends on technologies that are maybe run of the mill a little bit in a place like the United States, like polymerase chain reaction tests, centralization of health data and use of health data in certain kinds of ways. But these are technologies that are not widely diffused around the world. The kinds of tests that are being used for COVID in the United States, for example, are important in all kinds of settings like this. A major factor in the 2014-15 West African Ebola epidemic was how little testing capacity there was and how much that hampered the response to Ebola in Upper West Africa. And of course, that has remained through this one. The kinds of large-scale testing that is technically capable in the United States and has been deployed to a certain extent here, but really into a huge extent in countries like, for example, South Korea, is not widely diffused around the world. Testing has been, because of things like asymptomatic transmission of COVID, testing and centralizing data about transmission rates and prevalence in communities has been a major part of the response to the pandemic. And the fact that it's not diffused widely and that there are still plenty of places where these are technologies that aren't widely or generally available has been a major part of why the pandemic has had unequal impacts. Finally, this one may be a little bit crazy to mention, but genomic sequencing has been enormously important in the COVID-19 pandemic. One of the major features of the SARS-CoV-2 virus is how protein it is, how easily it is, how much it changes. And these variants of COVID different variants of COVID that have arisen over the course of the last year have changed the dynamics of the pandemic in many different ways. The one that we all have front and center, I'm sure, is the rise of the Delta variant of COVID through in the spring of 2021, and then the Delta-driven surge in the United States over the course of the summer. Delta is importantly different genomically from other strains of SARS-CoV-2. This has made it more transmissible. Realizing that it had these differences and that these differences made a difference to the transmission dynamics was really important in spurring the reimposition of public health measures like masking in the United States over the course of the summer. And that had a lot to do not just with observational evidence about transmission dynamics, but with evidence from genomic sequencing. Part of the reason why the Delta variant was identified also was because it arose in India, a country that has great capacity to do this kind of viral sampling and genomic sequencing. So as SARS-CoV-2 becomes endemic, a part of the viruses that circulate in the human population, diffusion of genomic sequencing technology to all the corners of the world to keep track of whether or not the virus is changing and how the different variants of the virus are affecting mortality and morbidity is very, very important. And the fact that it is not widely available kind of means that we're flying a little bit blind when it comes to tracking these things. All right, so I just want to draw some general lessons here, and I think collectively these lessons constitute an argument, not a knockdown, drag-out argument. I'm not going to say like, oh yeah, I'm definitely right and they're definitely wrong, but I think they're the seeds, let's say the seeds or the elements, the beginnings of a rethinking of the role of biotechnology in global health. So let me just make some general points here. First, I agree that clinical deserts, the persistence of clinical deserts, access to medicines, just basically structural injustices in the availability of healthcare resources are the most pressing moral problems in global health. But I think one of the things the COVID-19 pandemic has shown is that biotechnical capacity is essential to dealing with epidemic disease, emerging infectious diseases, which are clearly an important part of 21st century world, are not things that can just be handled with old-fashioned public health measures and with essential medicines. The things that we use to deal with the COVID-19 pandemic, testing, real-time viral genomic sequencing, centralization of data, the existence of complex supply chain, and manufacturing capacity for complex biologics like mRNA vaccines, monoclonal antibodies were really, really important for dealing with this threat. We should recognize that this is the case and recognize that the world needs action to ensure diffusion, not just innovation in these areas, but diffusion of these technologies around the world. I think one of the things that the pandemic has shown also is that it's time to maybe retire the penchant in global health ethics for fancy schemes to promote access to medicines and accept that we need some kind of reform of world intellectual property institutions. One example of this has to do with distribution of the COVID vaccine. COVID vaccine was developed under state plans that fall into this category of what are called advanced purchasing commitments. Essentially, so when in Operation Warp Speed, for example, the United States committed a bunch of money to all these different pharmaceutical companies who had technology available, promising technology available to develop a vaccine as fast as possible. And they said ahead of time, if you do it, we will buy X number of doses at Y price from you. That is a kind of way of financing pharmaceutical research and development that's called an advanced purchasing commitment. For as long as I've been studying medical ethics, economists, medical ethicists, people have been just cheering on the existence of these schemes. And scheme sounds like a dirty word. I mean, these programs, I say projects, for ways of financing medical innovation, especially for things like vaccines or new antibiotics, for which there's little market incentive to do it. The COVID-19 vaccine development process involved the biggest advanced purchasing commitment project in world history. And what has been the result of it? Wealthy countries in the world have advanced purchased almost every dose of COVID-19 vaccine that is going to be made until the middle of 2022. Right now, November 2021, 1% of the world that lives outside Western Europe, the United States, or wealthier countries in East Asia has been vaccinated, has received at least one COVID-19 vaccine dose. 1%. The world has made billions of doses. Only 1% of somewhere around 5 billion people have even received a single dose. Advanced purchasing commitments, it turns out, yeah, it kind of did work the way that a lot of global health theorists wanted it to. It spurred development of something that's kind of, that wouldn't really have, that seemed to not really have a big sort of market incentive to do it. But the result of that has been massive inequality in distribution of the vaccines. The world's scheme for distributing vaccines to lower income countries, COVAX, just isn't working, period. It hasn't worked out at all. And the pharmaceutical companies who made the mRNA vaccine have made quite a bit of money selling it to governments. The estimate is that, who knows what the figures are, but a good estimate, quality estimates put Pfizer and Moderna's and BioNTech's, who make the two most popular mRNA vaccines, profit this year at $56 billion from these things. I think that this shows that these kinds of things that leave patent laws and intellectual property institutions that govern technology transfer and things like that in place, but try to get around them by working out other ways to distribute medicines, like it's time to put this idea to bed. The COVID-19 vaccine should be licensed for generic manufacturer in other countries. There are a number of countries around the world that can make it. Besides where it's being made right now, India, South Africa, Indonesia, Russia, China, and Brazil all have the capacity to make mRNA vaccines. I think it's clear that the only way to address this inequality is to allow licensing of the vaccine and manufacture for generic use and distribution. And this should be a lesson about the role, this should just be a general lesson. We need to think very seriously about intellectual property institutions that govern technology diffusion, because the ones we have now are not working and are hampering the world's response to emerging infectious disease threats like COVID. Finally, like this is just a personal one. I don't know if y'all feel this way or whatever, but in the area that I work in, for the last couple of years, there's been a real fad to be very skeptical about biotech and about pharmaceutical and medical innovation. I think it's enough already with the skepticism. I mean, clearly, like like, the development of the vaccine, the resources we brought to bear on this thing, it shows biotechnology is good, medical innovation is good. There are things that are very problematic about it, but as a whole, views like Jacob Steganga's medical nihilism, that argue that this stuff kind of just doesn't work and there isn't really like a good role for it anymore in global health. No, I think it's time to put those to rest. They should have never really been very attractive in the first place, but a lot of people were attracted to them. I don't know if any of you care about it or into it. You can bring it up in the Q&A if you want to. I won't go into any more detail with it, but it's been a particular bugbear for me that there's all this skepticism among medical ethicists about medical innovation, and here we have an old-fashioned threat from the medieval past, an epidemic respiratory virus, and how have we dealt with it with 21st century medical technologies. I think this is enough to show biotechnology really has a big role to play in global health, and we need to think very seriously about that role and about ways that biotechnology can work better, medical innovation can work better to deal with these things when they do happen. So thank you all very much. Thank you for your attendance and your participation. And I'm looking forward to all of your questions.
Thanks, Brian. Appreciate it. That was a really great talk. We've got several questions in the chat, and I've been trying to organize these as you've been talking. I sort of see 3 different types of questions. So I'm going to give you that landscape first before I get into specific ones. We've got some questions about the relevance of history, past pandemics, and understanding COVID-19. So that's one type of question. We've got questions about the coupling of ethical issues. So you've talked a lot about the importance of biotechnologies, but also justice concerns. So thinking about how those are connected. And then we've got a couple of questions about the relevance of information complexity, like information systems that both distribute information more quickly, whether that's biomedical, but also open the door for misinformation. So that landscape. So sort of 3 flavors of questions.
Okay.
So I'll start with the first one. The first one is about the relevance of history. So are there, I wonder if you could talk us through, again, your view on the responses to previous pandemics compared to this one. One audience member had a question or concern that given how much we maybe should have known about pandemics, the COVID pandemic response could have been entirely avoidable. So there's a relevant disanalogy to previous pandemics.
Yeah, so that's a good question. Just talk generally about the relevance of the history to dealing with this one, and then that specific sort of concern. I mean, obviously there are things about COVID that are sui generis and that aren't like other things that have happened in the past. Some of this are endogenous to the virus is a certain kind of virus. It spreads in a certain kind of way and everything. A lot of these are just because the world is very different now. One of the things that's makes COVID very different has to do with the nature of coronaviruses generally. I mean, coronaviruses up until very recently were considered to be not a big public health threat. In the first 22 decades of the 21st century, now we've seen 3 coronaviruses that are extremely deadly emerge, 2 of them that are really bad but just aren't very transmissible, and one of them that has a lower mortality rate but still is pretty nasty and is extremely transmissible. There's a lot of talk that maybe coronaviruses are the pathogen of the 21st century. Things that there are features of our world now, increased urban development in what's called the wildland urban interface, air travel, things like this, that make it the case that a pathogen that works like COVID and works like SARS or MERS does, just has a lot of opportunity to spread. And much like tuberculosis was the disease of the 19th century, things like TB and cholera, for example, were the diseases of the 19th century because they thrived in crowded, unsanitary urban conditions. Coronaviruses, which cause mostly mild respiratory illness until you realize it's too late, are the disease of the 21st century. They emerge in certain kinds of situations that are very prevalent in our world now that haven't been in the past, and they spread very rapidly because we have things like international air travel and stuff like that, and they present as respiratory illnesses, and so they are indistinguishable in many ways from the flu and other things like that. So there are definitely things that are just very different about this, but history, I think, is extremely relevant to understand it. First of all, history is relevant to understanding this one because it helps you understand what's different about this one and not the same. I mean, this one is very different from other ones in many respects. The way we can figure that out is by comparing it to how we responded to the Spanish flu, how we dealt with, I think the real interesting comparison, honestly, is the 1957-58 flu pandemic, because that one was less serious than this, for sure. But I mean, the response to it was totally different. There were not widespread lockdowns or masking or anything like that, and it killed a lot of people. And it not just killed a lot of older people, it killed a lot of infants and children. And so, just sort of comparing this one to historic ones is very important to understand what's different about this one. But a lot of things have just flat out been the same. I mean, which is sometimes depressing when you realize how different the world is, and yet a lot of people's responses to some of the responses to COVID have just been the ones that have been there for a long time. So just one example, early in the spring, one of the ways in which many people have, early in the spring of 2020, when COVID transmission was taking off around the world, and it still was not totally understood how, seriousness and stuff like that. There were widespread exoduses from urban centers in China, the United States, and Europe. People just left New York City and rented Airbnbs in upstate. People left. People got out of Wuhan as fast as they could ahead of the Chinese government's lockdown. In Italy and Spain and France, which were very heavily affected in the spring, people left Paris and big cities and stuff like that. I mean, that's just been a part of the way people panic and respond to infectious disease from the Black Plague on. So I think history is relevant, but shouldn't be overstated, I guess. As far as the specific question about the pandemic response, I don't think anybody thinks that it had to happen this way. We were more prepared than ever in human history for something like this. We had a playbook for dealing with it. I think everybody thinks we should have been better prepared and things could have been handled a lot differently. But, this is something that people will pick apart for 100 years. I recommend a book that I'm reading right now called The Plague Year by the journalist Lawrence Wright. It's just basically an instant history, sort of play-by-play of what happened over the course of 2020. And I think it's really good for doing this kind of autopsy, let's say.
Yeah, thanks. That's a good segue to a couple of other questions from audience members that have to do with the role of information, let's say. And I'll just share, I'll start by sharing a story. I inherited a scrapbook of this woman who lived in Indiana at the turn of the 20th century. And it's got just newspaper articles that she pasted in this scrapbook. And there's a whole section on the 1918 flu pandemic. And it struck me that the sort of like public editorial responses that were being published then could have been published in 2020. So there's same sort of like distrust and misinformation campaigns and questioning public health responses, all of which we've seen now. But one of the questions we got in the chat specifically was on COVID-19 and the impact of misinformation, right? So how did misinformation play such a huge role, and could it have, if it hadn't been for misinformation, would we have overcome the pandemic differently? And would it be ethical to impose consequences for the spreading of misinformation as a public health response?
Yeah, I'm not an expert in this, so I'm just going to offer an opinion and just take it as literally just one man's opinion. Like, there are people who are experts on health communication and public health policy, and they're the ones who are going to have to ultimately legislate on this question. But just my opinion, so obviously the spread of information, different kinds of information, and different sources of information, spreads of different kinds of information has been a major impact here. But I think what you said about the scrapbook is very important. This is one of those things that isn't different about this one. People believe a lot. I mean, people have believed a lot of stuff. There's been a lot of information floating out there. People are scared and panicked and have been trying to learn everything they can. Some of it has been good. Some of it has been bad. Some of the bad stuff has had bad impacts. A lot of the stuff that people say, a lot of the objections that people raise to strict public health measures were the exact same ones that were raised in different cities in the country in 1918. There are famous comparative case studies about this. Philadelphia did not impose strict public health measures when the flu got really bad. St. Louis did. People in Philadelphia, if you look at newspaper editorials from the Philadelphia dailies at the time, I mean, they could have been posted on Facebook last year. And the city government in Philadelphia caved and didn't shut the city down, famously let some big public events go forward. Philadelphia lost tons and tons and tons of people. Guys in St. Louis did not. St. Louis weathered the storm much better. I could just replace all those names. I could have replaced dailies with social media, and I could have replaced Philadelphia and St. Louis with Texas and Oregon, and it would have been and everything else in what I just said would have been the same. So, I mean, it's a little bit weird to me to hear people say this is like a major dynamic of this one that we have to deal with. It's been a dynamic of every epidemic, period. Medical historians have documented the role that rumors and unfounded beliefs and taboos about various different kinds of things play in shaping behavior in epidemics, and this one is kind of par for the course when it comes to that kind of stuff. The second question is interesting. The second part of that question, I just, I'm not going to say anything. I don't think, because I'm not an expert on this, man. You got to ask a public health ethicist. Consequences for speech that has had bad impacts through spreading of misinformation. I'm just not going to offer an opinion. Not because I don't want to, but honestly, this thing is still going on, and people who have expertise in specific areas should talk about those areas and then just not talk the ones that they don't know anything about. In 20 years, when it's not going on, and we can just talk about this in the armchair hypothetically, then I'd be more happy to give a talk about it. But for right now, there are people who do this for professionally, public health ethicists, for example, and I'm going to let them weigh in.
Yeah, so you're heading off two other questions, because there are two other questions that are on the same theme, like the tensions between public health values and personal freedoms, and the responses to like vaccine resistance, and from a public health perspective. So I wonder if you could just go one step removed from that and talk with us a little bit about your sense of the relationship between public health ethics and biomedical ethics, because I think there's some real life tensions there.
Yeah, that one I'm happy to talk about. I mean, I think I have a little bit of an unorthodox opinion about it. I do not think concerns about personal freedoms are misplaced in this area. I think there is and should be very serious concern about how much we think the state should be able to do in the interest of securing public health. And I think everybody should in particular wonder whether or not certain kinds of actions will set precedents for the next one, or even not the next one, even just something we say is a big problem, a big public health problem in the future, but is not an infectious disease. And it is perfectly legitimate to say there are trade-offs involved here, and we need to be careful about what we're willing to give up for the sake of public health. I don't know what that translates into for specific actions, like vaccine mandates, let's say. I mean, this is one I'm not going to touch with a 50-foot pole. But there is an awful lot of, I think, kind of condescending and sometimes very angrily dismissive sort of noise from especially some biomedical ethicists about concern for things like the trade-offs with personal freedoms and public health measures. And that is not right, man. Public health is a powerful justifier of coercion, a very powerful justifier. You can get away with making people do things when they're scared of getting sick that they would otherwise resist. Situation in China in the late winter and spring of 2020 should be a very serious cautionary tale about what happens when you basically say, secure the public health at all costs. So there is definitely trade-offs here. These trade-offs should be carefully thought about and weighed. How that translates into specific policy action, I'm not a public health ethicist, so I'm not going to weigh in on it. But I have been frustrated. But as a medical ethicist, I mean, one of the central dilemmas in medical ethics is and always has been the trade-off between personal autonomy and health. And on the individual patient level, we accept that people can make decisions that negatively impact their health all the time, up to and including refusing treatment that results in death, if that's what they want and that's what they believe, and the risk is mostly on them. Where this question about the interrelation becomes enters in, so you can't scale up one into the other, is that obviously in public health scenarios, you're not talking about risk just to you. I'm not talking about refusing a transfusion that means only I die. I'm talking about refusing something or refusing to do something that impacts many, many other people, and that raises a whole other thing. So I think that's a different set of ethical questions from the one that I typically deal with. But I will say, even though I think it's a little bit unorthodox, I'm frustrated and actually kind of a little angry. The number of medical ethicists who have been very quick to say we should definitely have vaccine mandates, and these people are crazy. They're not crazy at all. Everybody can read the news. I mean, some people are crazy, but everybody read the news in February 2020 and saw what happens when you empower the state to do whatever it thinks it needs to do to secure public health. There is a trade-off there. These need to be thought about carefully.
Yeah, that's helpful. And there's another attendee in the Q&A mentioned there's also this question about education, right? That there could have been better education, or there always could be better education to inform the public about what public health responses are there for and why, as a means of like differentiating coercion from encouragement or something. But your point's well taken. I want to shift direction before we run out of time, because there's a big part of your talk was about, or a big component of your talk was about IP reform. And I wonder if you could talk a little bit more about, one of our attendees asked to explain in more detail what kind of IP reform he thinks needed. Are you suggesting that COVID-related innovation should not have been protected and should have been placed in the public domain? Are you suggesting that like background IP should be dedicated to the public? What's the landscape?
No, I don't think we should scrap patent institutions at all. I think they are essential to the structure of the industry and to R&D and innovation, and they are here to stay, and they should not be dissolved. Whether we ever should have had them in the first place, whether there's some ideal system that doesn't involve patents, I don't know. My favorite quote about this has always been from the economist Fritz Machlup. He did some of the most interesting economic work on property and intellectual property. Middle of the 20th century, he was testifying in front of Congress about patent reform. And he was asked by a congressperson straight up, do you think we should have patents? And he said, if we did not have a patent system, I could not in good conscience recommend creating one. Since we have one, I cannot in good conscience recommend scrapping it. So I do not think we should get rid of IP, but I do think that the IP institutions that were put in place during the global agreement on tariffs and trade and have been part of the WTO structure governing this area for a long time now are just not working. What I would like to see is serious consideration about the level of what's called the level of patent exhaustion. Right now, all the signatories to the global agreement on tariffs and trade, everybody who's part of the WTO, in other words, accepts that patents are exhausted at the international level. If you have a patent in country X, you have a patent in every country that's a part of the WTO. Intellectual property institutions are not one size fits all. In some countries, it makes sense to give people a 20-year patent on a molecule and exclusive rights to make it and distribute it, all kinds of things. In other countries with different sorts of healthcare needs, different sorts of medical systems, and different ways of financing R&D, that doesn't necessarily make sense. I think the COVID vaccine is a good example of that. Pfizer, BioNTech, Moderna should all have patents on the COVID vaccine. They developed this technology over decades. They had it ready to go. All they needed was somebody to take away the risk for putting their labs into process. The minute that risk went away, they instantly converted all of their efforts to making this vaccine as quickly as is safe. They conducted one of the world's largest ever clinical trial, and they got it out less than a year, after the pandemic started. This is a feat of human ingenuity comparable to landing on the moon. But does that same patent that works in the United States and Western Europe also work in Africa, in South Africa, in India? I think the answer is no. What I would like to see is serious work on figuring out a way to have patents exhaust at the national level, meaning that you have a patent that works in the United States, but having a US patent doesn't mean you also have an India patent. You have to file separately for the kind of patent that works in India. And there be more sort of mechanisms available to push licensing or manufacture of generics in countries that are having trouble importing doses made in Western Europe. There's always been significant worries about this. I mean, I've heard all the, I'm sure people are typing it in right now. I've been studying this for a long time. I've heard all and agree and also worry about all the worries about gray trade in off-label generics, about whether or not this will chill incentives for innovations that impact these countries. I think these are big worries. I really agree. And pharmaceutical companies are right to raise objections about this. But again, there's a trade-off here. What we have now is suboptimal. I think it's worth exploring whether or not another application that also has risks and drawbacks is maybe better than the one we have now. That's what I mean by IP reform. I'm for piecemeal change to international IP institutions. And I think the two that I just mentioned, more flexibility about licensing, especially in public health emergencies, and serious consideration of level of exhaustion for patents, the COVID vaccine situation is evidence that those are, like, the way we do those two things now is no good, and it's time to explore alternatives.
Yeah, thanks. That's helpful. I mentioned 3 types of questions that I sort of identified. We talked a little bit about the history questions, the role of information and misinformation. And a third type was about the way that ethical issues are coupled together. And so we've got a question from a participant who asked about how do you think marginalized communities could better prepare for future, or could be better prepared for future pandemics and outbreaks? And that question really struck me because you've emphasized in this talk in particular the role of biotechnologies as you define them, but also talked a lot about, I don't think you used this phrase, but the idea of like orphan diseases, the idea that there have to be other economic incentives to overcome injustice issues. And so there's this coupling of biotechnologies and this bigger sandbox of ethical questions. So I wonder if you could just talk about that landscape a little, maybe in response to this question.
I can, but I'm going to keep my comments just to the stuff about biotechnology, because again, I don't want to weigh in on stuff I'm not I don't do a lot of research on and don't have some actual expertise in, and also genuinely because there is a very large literature about this that I just don't know very well. I mean, medical ethics is a massive field with lots and lots of work, and I know like the parts that I know and enough of the other ones to teach them. So I don't want to, this is so much discussion about this and so much good work out there. I'm not gonna, I don't want to talk about that because I just don't know enough to say anything productive or useful. But about the stuff that I talked about now, for a very long time, diffusion of novel technologies has been a big problem that developing countries have been pushing the world community to take more seriously. It began with the Doha round of WTO talks. India and South Africa pushed heavily. This is especially about, especially at that time, it was about novel antiretroviral medication for HIV/AIDS. Just never really went anywhere. Fast forward now, 2021, India, South Africa, Indonesia, China, Brazil, these are no longer up and coming economies. These are major geopolitical powers and players. They have serious clout now to push for real change. This is a wake-up call to the world. I think that communities like, I don't know if this is exactly what the person who asked the question meant by marginalized community, but I'm assuming it meant things like developing countries that don't have significant biotechnical infrastructure, have a lot of people living at the bottom of the income scale, having trouble accessing primary healthcare. So for that community of people, governments that can speak for them, the South Africas and Indias of the world, need to seize this moment to really push hard. India in particular has a lot to trade. India is one of the world's largest users of coal. Everybody in the world wants India to stop burning coal. Seems like a trade can be made here, a deal can be made. India can do something for the developed world, and the developed world can do something for India by working on them with healthcare infrastructure. This is what I think they should do to better prepare for the next time. I think they should push the world to share the technological resources that have made such a big difference in Japan and South Korea and the United States and Canada with the countries that did not have this biotechnical capacity and have had to deal with much more severe intranational pandemics than they would have if they had better stuff. It's maybe an unsatisfying answer, but sorry. That's the best I can do for you right now.
It's the best I can do for you now.
I appreciate the call, the sort of recognition to stay in the expertise wheelhouse. We had a really interesting talk as part of the Center for Ethics on the idea of epistemic trespassing, the idea that oftentimes we're prone to like speaking outside of our expertise area. And I think that's an important recognition there. I think there's a lot more to talk about, but maybe one question to bring it, to connect the history to the biotechnology again. Looking forward, we had a question here that suggests like looking forward to the next pandemic or endemic. Do you think in the future, now that we've got mRNA technologies rolled out, does that mean we're better prepared for the next pandemic, or are we no better prepared than?
Oh yes. Oh my God. Absolutely. The mRNA platform is a game changer for dealing with these things. An absolute game changer. I mean, there's been a lot of discussion about this. For example, suppose we didn't care anything about patient safety or whatever, and we just started manufacturing the vaccine candidate and distributing it as soon as it was done. Could have had a vaccine by June of this year. I mean, when you have a brand new thing like that, that would have been totally wrong, extraordinarily unethical. Doing the clinical trial was absolutely necessary. No way you should have done that. But now we did it, and we know the platform works. You can treat this thing. I mean, not quite yet, but with successive iterations of development, eventually we can treat this thing the way we treat manufacture of the flu vaccine. You don't have to test every year's flu vaccine. You make these things in the same way every time. Just put new stuff into it. So as soon as you get the stuff and it's time to roll it out, you roll it out. Eventually, the mRNA platform will be like that. As soon as one comes up, you just make it and you manufacture it and you roll it out as quickly as possible. No doubt this has changed the world's flexibility. We're dealing with epidemics. The next one, and there will almost certainly be a next one, hopefully not for some time, but the next one that happens, I would imagine this is the right kind of, this is the response. Here it is. Let's shut down right now because we don't have to wait that long to reopen. In 6 months, we'll be mass vaxxing everybody. So we're going to take a temporary hit on social life and economic stuff because, we're going to get this vaccine out very, very quickly. It was almost, it's just that it's just that this was a new platform, a new way of making vaccines, and it needed to be rigorously tested as if it was a new drug, because it was a brand new drug. But I mean, there was a vaccine candidate 6 weeks after the genomic sequence was there. If you have, and again to my point about spread of biotechnical capacity around the world, if you have supply chains in place and manufacturing capability to scale up manufacture, the minute a vaccine candidate is available, we're talking about response to epidemic diseases like this that are measured in months instead of years. And it is absolute. I think it is totally the case that because we used this opportunity to make this technology happen, we are better prepared for the next one. And we can deploy this thing in ways that will lessen the impact of epidemic diseases in the future. I mean, just one example. I mean, imagine you really do develop a universal flu vaccine. Then there are no more flu pandemics. I mean, there kind of are in a certain sort of way, but not the ones that people are really afraid of. Not something like 1918 doesn't happen again. So I think that is definitely, I'm high on the technology that's been developed for this pandemic. I think it's really, really interesting and important. I think it is the life science, the development of the mRNA vaccine, and some of the other stuff that have been put in place are the life sciences equivalent of landing a person on the moon.
Ryan, thank you so much. I love the ending on the optimistic note. Thank you so much for your time. It's really appreciated. We'll turn it back over to... we'll turn it back over.
COVID has actually given the world a reason to be optimistic. COVID has been a terrible thing, but some of the things that have happened this year have actually, I think, given me personal reasons to be optimistic about especially certain parts of like our epidemic disease response that were big mysteries before this happened. And now I'm kind of like, all right, well, these things are going to happen. They're going to be part of the 21st century world, but we do have ways to deal with it. And I think that's a reason to be a little bit optimistic. I mean, it's kind of like learning that tornadoes will happen, but they don't have to be as deadly as they have been in the past.
I like it. A little bit of optimism goes a long way, especially right now.
Cool.
Dr. Kubler?
Well, thank you, Dr. Cwik, for sharing your insights into global health and what we've learned from the COVID pandemic. Thank you, Dr. Weber, for moderating our Q&A session, and thank you, participants, for your outstanding questions. A link to this presentation will be made available on the UCF Center for Ethics website, so you can view the recording and share it with others. And there you can also see links to past talks and information on upcoming presentations in Ethically Speaking. I hope you'll plan now to join us for our next event. It promises to be very unique. On November 30th, Professor James Franklin of the University of New South Wales will speak about quantification in ethics. Now, although most of us probably think of ethics as deeply personal values that can't be objectively measured, Dr. Franklin will show how society quantifies values all the time in many activities, such as insurance, healthcare, and the allocation of public funding. Do sign up for that webinar by visiting our website at ethicscenter.research.ucf.edu. You'll also find information about the center's other activities, as well as contact information to provide feedback and ideas for future talks. Ethically Speaking is made possible by generous support from the many UCF colleges, departments, and units listed here. And I'd like to thank those partners and many individuals in those units who helped bring this series together. I'd also like to thank the Office of Instructional Resources for technical support, the College of Arts and Humanities for promoting our event, and Mrs. Tomiko Fukuda of the Chemistry Department who manages finances for the series. Lastly, thank you for your participation, and we hope you'll join us for future presentations in Ethically Speaking.